Great. Thank you, Emily. So good morning, everybody, and thank you again for joining us for Grand Rounds this morning. We've seen this is an incredible format for improving our participation in Grand Rounds. So we're going to, in some way or another, this is one of those learning episodes that we're going to be applying long after the current shelter-in-place order expires. Again, not too much new to say. We are working hard to get labs reopened. I just saw this morning that there is a new energy around reopening clinical research. So I think that is very good news for all of us involved in clinical trials. I'd encourage everybody to continue to work through their virtual visits. We obviously need those to help keep the department moving along. I think there's supposed to be new changes to Amwell that are going to make this a little bit easier. So with that, again, good morning, and I'll turn this back over to Dr. Borman-Shope.
Well, good morning, everyone. We have a special named lectureship this morning, so I'm going to start with letting Dr. Paul Orchard from our Bone Marrow Transplant Division give a little background on the Krivit lectureship, and then I'll let him introduce our speaker.
Great, thanks, Emily. So yeah, before I introduce Erica, I want to talk a little bit about why we have a Krivit lectureship and who Bill Krivit was, for those of you who don't know him or his contributions. But so Bill was a professor of pediatrics. He was here at Minnesota on faculty, I think, for over 50 years. He was the chair of the Department of Pediatrics, but in the division of hematology, oncology, and transplantation. He published extensively, both in the fields of coag and hematology, but especially in bone marrow transplantation. And Bill was really known, I think, primarily as a pioneer in the use of allogeneic transplantation for non-malignant diseases. And he was instrumental in the first transplant for lysosomal disorder in this country, which was done in Minnesota. We lost Bill in 2005, but we remember his contributions to the field, and through that, the lectureship was established. So I think this is the 19th lectureship, of the Krivit lectureship. And this year we have the privilege of having Erica Barnes present today. So Erica's family was touched by these diseases. She lost a daughter, Chloe, I think about 10 years ago now, to metachromatic leukodystrophy. But she and her husband, Philip, established an advocacy group, Chloe's Fight, that have helped raise money for research in the field. And Erica was really instrumental in getting legislation passed at Minnesota to help establish a rare disease advisory council for the state. And she serves as the medical director of that council, which is chaired by Dr. Tolar. She's also been involved nationally, the National Organization of Rare Disorders, or NORD. She's the Minnesota representative of, she's served on other groups, including the GLIA, the committee, and the MLD Foundation and whatnot. So Erica has a unique perspective on these rare disorders and how they touch families and providers, and how we might interact to help best provide care for these patients. So without any further ado, so Erica, we appreciate the opportunity for you to present for us today, and I would look forward to your talk.
Thank you. Thank you so much, Dr. Orchard, for that kind introduction. I'm going to pull up my screen here, my presentation. I'm going to just quickly sorry. Okay, so thank you again for that introduction, and thank you, Dr. Borman-Shope, for inviting me to present on a topic that I obviously feel very passionate about, rare diseases. The title of my lecture today is When You Hear Hoofbeats, a New Perspective on an Old Axiom. And I have a few objectives today as I give this lecture. I, first of all, want to familiarize all of you listening with some of the characteristics of the rare disease community in which my daughter belonged. I want to identify some common barriers to care, with a particular focus today on the barriers to diagnosis that rare disease patients face. And then I want to give you some tools for improving care for rare patients. So those are my objectives today. I don't have any financial disclosures, so I'm going to skip that slide quickly. Dr. Orchard already gave a good introduction of me, but to just kind of walk you through my journey a little bit, I'm first of all a mother of a child who is diagnosed with a rare disease. So that's Chloe and I, actually at the Mayo Clinic. That top picture as we were going through the diagnostic process, trying to figure out what was wrong with Chloe. Chloe was eventually diagnosed with metachromatic leukodystrophy. Many of you on the call probably know, but for those of you that don't, that's a lysosomal storage disease. It's aggressively neurodegenerative. So she received a bone marrow transplant at the Mayo Clinic in 2010, and she actually passed away shortly after the bone marrow transplantation from complications from the transplant. After that, my husband and I started to get involved in advocacy, and we eventually founded Chloe's Fight Rare Disease Foundation. The mission of Chloe's Fight is to raise funds for research for lysosomal storage diseases and also to raise awareness for the barriers to care within the rare disease community. As Dr. Orchard mentioned, I also got involved in advocating for legislation to establish a rare disease advisory council here in the state of Minnesota. That bottom picture is the rare disease community at the bill signing with Governor Walz. And that is proof that he did do things other than give COVID updates at one point. So that's last year in 2019, the bill signing. And the Rare Disease Advisory Council is established here at the University of Minnesota in the medical school. And I administer that Rare Disease Advisory Council under the direction of Dr. Tolar. So I want to start out this talk today by presenting Chloe's diagnostic Odyssey and kind of presenting it as somewhat of a case study to sort of present some of the challenges that rare disease patients face. For those of you who maybe aren't familiar with the term Diagnostic Odyssey, that's sort of the slang, as it were, that we use in the rare community to characterize the journey that a patient that's eventually diagnosed with a rare disease takes. And Diagnostic Odyssey being a term that indicates the difficulty that we have with finding a diagnosis and the arduous nature of that journey to a diagnosis. And Chloe's case will illustrate a little bit of that, although she did have a much faster time to diagnosis than the average rare patient. So Chloe was born in 2008, and she really had a clean bill of health. There was nothing at birth that indicated there was anything wrong with Chloe. And of importance to note is that nothing was identified on the newborn screen. So nothing came back as unusual for Chloe. I'll talk about newborn screening a little bit later, but suffice it to say that when Chloe was born, we had no indication and no idea that anything was wrong. She was our second child. And for about the first year of Chloe's life, there was no real concerns. Although as I look back and I read back into her journey, there are a few things that I wonder if there were some early indications that Chloe's development was a little bit off. But it really wasn't until about 14 months of age that I started to have some real concerns about Chloe's development. And they were just very subtle signs, but they became more and more concerning to me. So I actually have a background in speech pathology. And at the time I was working in a rehab in a hospital, and I was working with stroke patients and patients that had sustained brain injuries, but also I had a few patients on my caseload that had MS, and also I had had a little bit of exposure to the ALS community. So I started to have some concerns about Chloe's development, and those concerns were difficulty. I was noticing she was having some difficulty with balance. She was having pain issues, and they seemed to really be more pronounced at night, but I couldn't localize where the pain was. So I was reporting just sort of pain issues to my pediatrician. And then it seemed like she was having recurrent respiratory infections. I will note that her initial pediatrician and the initial provider was very reliant on my reporting because her symptoms weren't consistently present. So for example, I would take her in to see the pediatrician and I would say, Chloe's just in pain a lot. But in the doctor's office, she would be happy and smiling because of course that pain was intermittent. And I would also report things like, Chloe it doesn't seem like her body can do what her brain wants her to do. But these were things that the initial provider couldn't necessarily see himself in that initial visit. The other thing that I want to note is that because of the fact that I couldn't localize Chloe's pain, I was coming to the pediatrician with requests for just inappropriate tests. And I think that sort of set him and I off on a little bit of a maybe off on the wrong foot because, again, as someone not medically trained, I knew there was something wrong with my daughter, but I couldn't quite figure it out. So for example, I remember going into the pediatrician and saying, gee, I just wonder if she has a deeper ear infection. And even though you're checking for ear infections, is there a way you can see if there's just an infection that's a little deeper than your tests are showing? So I'm sure that sounded very strange to the pediatrician. I also remember that she had a small lump on her neck. And I thought, well, maybe she's got some sort of problem and that's causing her inability to balance. So I think because of the fact that there was legitimacy to the fact that my daughter was having pain issues, but I was asking for things that seemed a little strange. Perhaps the pediatrician stopped taking me as seriously. I don't know, that's just a hunch. But I eventually really wanted an MRI for Chloe, but the pediatrician wanted to take a wait and see approach. So he had ordered physical therapy for Chloe, and she was diagnosed with hypotonia, or she received the label hypotonia from the physical therapist. And my primary care provider, the pediatrician, wanted to wait for the summer to see how Chloe improved with physical therapy. And I remember just being very alarmed by the fact that he wanted to wait for 3 or 4 months. So my husband and I sought a second opinion, and eventually Chloe was diagnosed with metachromatic leukodystrophy, and she was referred to the Mayo Clinic for a bone marrow transplant. But I want to take a minute here just to give people an opportunity to reflect and to ask some questions. And I want, if anybody has some feedback or anybody wants to talk about this, or Dr. Orchard, if you want to jump in, as a provider, how would you have approached this situation? So being able to differentiate between a parent who's maybe overly concerned and a parent that's picking up on subtle signs. I'm also very curious. I threw in this next question. Would you consider the caregiver's level of education or expertise? And the reason I threw that in is I have to say that I was a little bit surprised that the pediatrician didn't seem to take into account the fact that I was a speech pathologist and I had some exposure to patients with neurological involvement. And I just wonder if anybody wants to give feedback on these questions, or if anybody has a comment to make. So I'll just pause for a minute in my lecture to see if anybody wants to ask any questions.
I would just encourage everyone, both if you have a question, but also at any point, if you have an experience that you'd like to share, you can note that in the question and answer, and I can give you the ability to talk and ask your question or share your experience in that way. Eric and I were chatting about how giving these webinars is a great way to reach a lot of people, but you're also sort of talking into the void, so you don't quite know what your audience is thinking. I'm a general pediatrician, so I could have been that person that you were bringing Chloe to come and see. And it is really challenging when a parent asks about something. You're like, why would you? That's not a thing, right? Like, there's no such thing as a deep ear infection. And so I think that one of the things that we certainly talk with the residents a lot about, and I know you're going to get into later, is just the diagnostic process in general, and when we do our sort of quick decision making, and when you sort of slow down and really try to be methodical and thinking through your differential. And one of the things that I try to do, which can be a challenge in a busy clinic morning, is just to pause and say, well, how often does a parent say this to me? If it's something that's quite different, then you just need to pause and just be curious. And I think the thing that I've gotten more comfortable doing is to kind of open up that Pandora's box and say, well, tell me more about what's got you the most worried, or what is it that really makes you think that this is pain and not the fact that she just doesn't want to sleep in her own crib, or, you know, tell me more about what you're seeing with the balance. And the question I've found the most helpful is just to say, is there something in particular you were worried about? Because sometimes a family will say, oh, I've been reading and I really think that she might have a neurodegenerative condition. It's like, oh, okay, that's a conversation. Or they might say, I don't know, it just doesn't seem right. So I think it really helps you to meet the family where they're at, and it gets at some of that, you know, considering the expertise that every parent is the expert in their child, but they may bring additional expertise from their line of work that informs what they're thinking, or they may have a family member who's had experience with illness that informs what they're thinking. Looks like somebody's got a question here. Let me just take a look. Yeah, Chris Mortalis was just sharing that it surprises him that her pain wasn't investigated more thoroughly, and pain that wakes a child from sleep would certainly be considered pathologic pain. Yes, I agree with that. The challenge in a 14-month-old who maybe can say mama is trying, you know, I think a parent just sort of knows if they're in pain, but that a lot of 14-month-olds also have tantrums and don't want to go to bed at night. So I think that's your challenge in what you're doing every day, Erica, is trying to say, yes, most of the time they probably don't want to go to bed in their crib, but sometimes that's not what it is. It looked like someone had their virtual hand raised. So Robert Galvin, I'm going to turn on your mic. Let's see if this works. I think you're muted, but if you wanted to, okay.
So I think in this situation, what I would do is just go back to the physical exam. I think it's really important to do a detailed physical exam when there's a parent who has a lot of complaints. I think it can go a long way in a therapeutic relationship. That, hey, you know, my doctor's actually laying their hands and doing a lot of detailed testing. And you can pick up things from time to time that can lead to different investigations.
Yeah, I think that's great. I think that this is especially once you get the hypotonia diagnosis, I think that's when you start to, it's like all the little things stacking up, you know, yes, maybe it's just that she doesn't want to sleep in her own bed, but then she also doesn't seem to be as strong as other kids her age. And you start getting all these little things kind of ticking in the back of your mind. And, you know, I think we're spoiled in the university setting that it's easy for us to phone a friend or text a friend and say, hey, I just want to, seems sort of weird. I think it's probably nothing, but what do you think? And we don't always do that or send somebody on for a consult visit as quickly as we should. So I think that's certainly another thing to consider.
I will make the comment that even hearing your questions, I think one of the interesting things about the situation, it wasn't, and I will make it very clear, I don't think that initial provider did anything wrong. I don't think he, you know, I think he followed certain protocols, but it was really the sort of the mismatch between how aggressively I wanted us to get to the bottom of it and sort of the slower timeline that he was proposing. And to Dr. Borman-Chope's point, I remember saying, hypotonia is not a diagnosis. I want to know why she's hypotonic. And I remember him saying, well, sometimes hypotonia is a diagnosis and that's all you ever get. So for me, it was sort of I don't want to call it a lack of curiosity because that sounds very pejorative, but it kind of was a lack of curiosity on the physician's part to really say, okay, let's get to the bottom of this. And, something in me was saying it's important that we get to the bottom of this quickly. And like I said, I think I said in the lecture, I just remember thinking when he said, let's wait till the end of the summer for the MRI, I remember thinking she doesn't have that kind of time. So again, not being able to put my finger on something that was being done wrong, but just not really seeming to have as much curiosity to get to the bottom of what was going on with Chloe's development.
If you're comfortable, someone wanted to just hear a little bit more about the balance issues that you noticed with Chloe, and if those were something that she had seemed to be developing normally and then started to have trouble with her balance, or if she never had good balance.
Sure. Yeah, so I can very vividly remember Chloe being at the point where she could stand independently, and she didn't need to hold my hand. And remember, she was my second child, so I remember probably right around 12 months or 13 months, she was able to stand independently, and it just felt like she just sort of like never developed past that. And she didn't exactly regress, but she, 14 months, 18 months, 19 months, she continued to need me to hold her fingers. Looking back now, I think it was more the neuropathy that was causing that, because she did definitely have neuropathy. So as you can imagine, if you always feel like your feet are asleep, it's very, very difficult to balance. So I hope that answered the question. So it was, so she just never was, it wasn't a regression, but she was just never able to, she plateaued. And I just remember thinking, gee, for working so hard to try to get this kiddo to walk, she's sure not getting any better at it.
Great. I think that definitely answers the questions. And just to highlight, as Robert pointed out, a really thorough physical exam, but there's also a reason that developmental screening is the standard part of our well child checkups, because they're expected milestones. So it's not just developmental regression, but also developmental plateau that should be kind of raising our awareness that something might not quite be right. Great. Thanks for the questions, everyone.
Sure. Shall I move on?
Yep, I think we're good.
Okay, great. I'm gonna just quickly. Okay, so that's the portion of this that I'm sorry. Let me just having trouble finding my prompts. There we go. So that's the portion that's a little bit more personal to Chloe's story. And now I want to move into a little bit more of the broader conversation around the rare disease community. As after Chloe passed away, and she was obviously diagnosed with her disease was rare neurodegenerative disease, as we've talked about. I began working to raise funds and awareness, primarily for metachromatic leukodystrophy. But I started to come in contact with other parents and other people who had been working to raise funds as well. And I began to observe some striking similarities. So I would meet a parent that had lost a child, and they would tell me their story about reaching a diagnosis and then trying to help their child. And I started to notice that for the families whose child had a rare disease, there was these striking similarities in our story. And I remember thinking, gee, if you just swap out the diagnosis, our stories are almost identical. So I really started to see that there were barriers to care in the rare disease community. And I started to really identify more with the rare disease community as a whole. And I'll start with just sort of the basic definition of a rare disease. So a rare disease is defined as any condition that affects less than 200,000 people in the US. And as you can see, this corresponds to a prevalence of about 1 in 1,630. And collectively, these rare diseases affect it's a moving target, of course, because it's a prevalence definition, but they affect anywhere the estimate is between 8 and 10% of the population. The article that I cited is actually really good, kind of digging a little deeper into the statistics of rare diseases. Another thing I will note at this point is that in the rare disease community, the majority of rare diseases do have a genetic basis. So obviously, you can see from this definition that it's a purely a definition that's purely based on prevalence. So there's things that the rare disease definition does tell us and things that it doesn't tell us. And it doesn't tell us anything about the etiology of these diseases. And so there's roughly about 7,000 different rare diseases. So it's a very heterogeneous population in terms of the etiology of these diseases. But the commonality in all these diseases really comes from the barriers to care that we face. So how the rare disease community interacts with our healthcare system is really where you start to see these very strikingly similar characteristics that we can distill from the rare disease community. And I want to review some of those. And then this little graphic that I have from the National Organization for Rare Disorders actually has a few more statistics too. So the first thing is that there's low individual disease prevalence, and we're highly dispersed geographically. Obviously, with some of the diseases, they're more concentrated in some populations because of the genetic basis of these diseases. But generally speaking, because of the low disease prevalence, we're dispersed geographically. And the implication of that for you as providers is that there's often no medical expertise in our immediate vicinity. That's also compounded by the fact that there aren't that many specialists sometimes for rare diseases. So it's very common for a patient with a rare disease to really have only one or two experts with any expertise in their disease in all of the United States. So that means that we often have to travel. We don't have access to frequent care. The next thing that's very common in the rare disease community is that there's no support groups, certainly not in our geographic region, but also there's frequently no disease-specific organization that can provide education and support for a rare patient. I haven't been able to find in the literature exactly how many rare diseases actually have a disease-specific organization, but the number is very low. I very clearly remember that the primary source of information that my husband and I had to understand metachromatic leukodystrophy in terms of printed literature were medical journals. And fortunately, my husband and I both have the education level to be able, we had the education level to be able to understand those medical journals, but that's a big barrier to some families. And what that means when there isn't a source of information is that patients often become their own disease experts, and they do their own independent research. And I think what this, it's sort of the practical implication for you as care providers is that you're really going to have, when you have a rare disease patient, you're going to see really varying degrees of understanding and medical literacy, depending on where the patient is going for information. I think it's pretty obvious in our society that there's no lack of information sources out there, but their credibility varies. So you may have patients come that have been in Facebook groups that perhaps are providing information that isn't really reflective of best practices or good health information. So because of that lack of information out there, it really affects the patient's ability to be educated on their disease. The next thing that characterizes the rare disease community is significant delay in diagnosis. And this is what I'm going to focus on in the rest of my lecture today. And then the next point is that there's often frequent misdiagnoses. And the final characteristic of our community is that there's no available treatments for the vast majority of patients with rare diseases. So we go from this very difficult journey to obtain a diagnosis and this nightmare of fighting for a diagnosis and convincing care providers that there's something wrong with us or our children, only to arrive at the fact that once there is a diagnosis, once our children or we are diagnosed with a rare disease, there's often a lack of available treatments. So these are just some general characteristics of the rare community. I thought this quote was very powerful when I came across it in the literature. So Abby Myers founded the National Organization for Rare Disorders back in the 1980s, and she's quoted as saying, "Families affected by rare diseases represent a medically disenfranchised population that falls through the cracks of every healthcare system in the world." This was certainly true when Abby Myers began advocating back in the 1980s for the needs of the rare disease community. And we've made a lot of progress. I'll introduce you to some great resources and to some great progress that's been made to support the rare community. But I would say that this is certainly still the case, that it is still very difficult, and some of the metrics I'll show you will support this, that rare disease families often do still fall through the cracks, regardless of the healthcare system that we're talking about.
Erica, I wonder if you're probably about to kind of start talking about this.
No, that's
just struck by just the patient and family's ability to advocate for themselves and partner with their healthcare provider when there's so much that's unknown, either before the diagnosis has been made or after. And if you can reflect maybe on things that you've seen either in your own journey or you've heard from other families that healthcare providers can do when the diagnosis is uncertain or once it's known. You know, with the resident doctors in particular, oftentimes they're put in a position to care for a patient where they have extremely limited, exposure and knowledge about the specific disease process, but they have medical expertise about, how to make sure a patient is stable and how to gather the information. So are there things that you've seen healthcare providers do that work really well that we should keep doing? And are there things that you've seen people do that you think we should not keep doing?
That is a great question. And as you were talking, I'll try not to be too wordy on my response, because I could talk about this for a long time, and I'll mention this a little later in the slide, but it's a great question because in my own experience and even anecdotally talking to other families, and then as well in a paper that I'll cite later, having a rare disease there's a very interesting overlay to the decision-making models and the decision-making paradigms. What I found in one study that I'll cite later is that typically when someone is diagnosed with a very serious, chronic, often fatal disease, the decision-making paradigm tends to be very doctor-directed, very provider-directed. But because of the fact that in the rare community, there's such a lack of expertise, with the general medical community, patients tend to take a lot more ownership of their information and of their own treatment. And so I think one of the things that I'll talk about later, and I think it's so important, is really for a provider to have a level of humility to be able to say, and this seems so basic and so simple, but it goes so far for a provider to just be able to disclose and say, you know what, I don't know, I'm not sure, but I'm going to find out. And it's a balance, right? Because all through the process with Chloe, there were medical providers, well, even the physician that eventually diagnosed Chloe, his ability to say, I'm not seeing what you're telling me, but it definitely sounds unusual. We're going to really get to the bottom of this. So having physicians that are able to sort of find that balance of the humility to listen to a patient and their knowledge, but also still move the dial forward and not put all the burden on us as patients. I don't know if that answered your question very well, but it's certainly a huge part of helping patients with that journey, and that being able to navigate in the world of getting a rare diagnosis and treatment.
Yeah, no, that was great. Thank you.
Sure. Okay. So well, the thing that I want to focus on, that barrier that I really want to focus on right now, is diagnosis. And I want to talk about what makes diagnosing a rare disease so difficult. And there's a few factors that play into what makes diagnosing a rare disease difficult. And the first one is the population heterogeneity. So there's heterogeneity. There's 7,000 rare diseases. And in some of the literature I was reading, it was very interesting because and knowing that there's a genetic basis to a large portion of these rare diseases, there's been a lot of, obviously you all know, a lot of advances in the world of genetics. And while that's really great, it's also very overwhelming. So there's just been this explosion in the ability to get genetic information. But it's also, that can also be very overwhelming. You know, you've got 7,000 rare diseases and you're trying to figure out, first of all, if the patient in front of you even has one of these rare diseases, and then being able to make a differential diagnosis is quite difficult. Along with that, the low prevalence of these individual rare diseases makes it very difficult for a primary care provider to accumulate the expertise that's needed to make these diagnoses, obviously. So with all these 7,000 rare diseases, being able to get the expertise to figure out which one the patient in front of you has is very difficult. And then just sort of at baseline, low awareness among primary health professionals about rare diseases and the common barriers, and just sort of a working knowledge of rare diseases makes it very difficult to diagnose. Often, again, a lot of these rare diseases are syndromes, and there's, you know, a lot going on, and the diagnosis has to be made on, you know, sitting down and figuring out all these complex symptoms, putting the pieces together, and arriving at a diagnosis. And so this really leads to that fourth part of this pie, which is the diagnostic referral loop, is how Vandermarn et al. Describes this. So the situation is, you know, a patient presents with symptoms, a care provider makes multiple referrals to specialists. Those patients, and I don't have to tell all of you on this call, sometimes getting into a specialist can be very difficult. And if you have multiple specialists that you're trying to get into, you're waiting for those appointments. All the while, there's a progression of the symptoms. Invariably, a patient, or often a patient, is misdiagnosed and perhaps receives ineffective treatments. And again, the disease is progressing, the symptoms are getting worse. And so they go back to their primary care provider, and it just becomes this circular pattern of a referral loop until hopefully a final diagnosis is made. So this is a very typical pattern. And clearly, I think it's obvious that a rare disease is just inherently more difficult to diagnose than a common disease. That kind of goes without saying. But I do think that there are a few things that I want to hone in on that will hopefully help improve diagnostics for the rare community. And I really want to focus on sort of that point that it's pretty established that there's low rare disease awareness among primary health professionals. And that gets me to the saying that I came across in my journey of advocacy. And the saying is, when you hear hoofbeats, look for horses and not zebras. I don't know if any of you on this call actually heard this in your medical training, or a variation. Certainly maybe this saying isn't getting thrown around the way that it used to, but this idea that common diseases are common. And from what I understand of this saying, the idea behind it is, really a caution for medical students and people just going into providing care to not get distracted with looking for some exotic rare disease, but really focus on the likelihood that your patient is going to have a more common disease. I actually, the last time that I was confronted with this axiom, or the variation of this axiom, was actually when I was working to pass the legislation for the Rare Disease Advisory Council. And one of the legislators that I was working with is also a trained physician. And I remember sort of talking to her about some of the goals and the aspirations of the legislation. And when I mentioned to her that one of my aspirations for the Rare Disease Advisory Council would be to really shorten that time to diagnosis and really focus on getting physicians to think about diagnosing and making it a priority to diagnose rare diseases, she said to me, well, in medical school, we're really told to focus on the common diseases, and we're really told that you really shouldn't sort of go down the rabbit trail of looking for a rare disease. So she certainly confirmed that this is something that sometimes is present, that this seems to be an attitude that's sometimes taught. And as I thought about this, and I thought about this axiom, there's really three assumptions that I want to challenge today about this axiom. So I'm going to go through these three assumptions that I see sort of inherent in this axiom. So the first assumption that I see is the most obvious, and the assumption that I think this axiom makes is that rare diseases are rare. And certainly, if you think of rare diseases in a silo, and if you think of them, and it's to be expected because there hasn't been a lot of collective consciousness in the rare community in thinking of these individual 7,000 rare diseases collectively, but it really requires that we use siloed thinking. And I think that this is just inaccurate in the sense that if you think collectively, there are 7,000 rare diseases and they really encompass a lot of diseases. And I just I threw a couple of names out there on this slide. So I understand. So will the majority of you on this call ever diagnose a child with metachromatic leukodystrophy or ever be confronted with a child like Chloe with metachromatic leukodystrophy? Obviously not. Obviously, the majority of people on this call are not going to necessarily see a child with metachromatic leukodystrophy. But at some point in your career as a provider, will you have to diagnose somebody with SMA or muscular dystrophy or ALS, any of one of the 7,000 rare diseases? The likelihood that somewhere in your career you will be confronted with a rare patient of some type is pretty high. Another point that I will make, which is a little bit of an aside, but I think it is true, is that the growth of precision medicine is really going to require that physicians shift their paradigm anyway. And I think we'll see a lot more individualized medicine, and that's sort of the future of medicine. So being able to think more specifically about patients is going to be something that is going to be required of care providers. So the next assumption, as I thought about this axiom, that this axiom makes, is that common diseases should have a higher priority. And again, this makes sense from an efficiency standpoint and from a, let's be efficient in our medical practice. Let's not go down rabbit trails. I do really understand that. But it really feels a little bit more like medical utilitarianism to me than really patient-centered practice. And I think, thankfully, medicine there is a real focus on patient-centered practice. And I think that's really great. So I get that, probability and statistics are great and it's great to be efficient, but what happens when you are confronted with that zebra? So what does it mean for the zebras to really just say, let's focus on common diseases? And I have some metrics here, and I think that they really illustrate the impact of that mindset on these children and on these families. So the average time to diagnosis for a rare patient in the US is 7.6 years. And I've met families that have waited far longer for a diagnosis. I've obviously met families that have gotten to a diagnosis faster, but if you think about a disease like metachromatic leukodystrophy, Chloe didn't have 7 months to wait for a diagnosis. She really needed to have that diagnosis quickly. So that 7 to 6 year average time to diagnosis it's just really a terrible metric. Also, rare patients are misdiagnosed an average 2 to 3 times. And then a rare patient will see an average 7 to 8 different providers before they reach that diagnosis. So the impact on the rare community to not being prioritized and not being considered it's a very significant impact. The other assumption that I think this axiom makes is that diagnosing a common disease versus a rare disease has to be an either or. And again, I think this is where it's very exciting to see some of the progress that's being made in medicine right now, because especially in the area of genetics, because of the fact that so many of these rare diseases have a genetic component. I think that we're moving away from really needing to make this either or sort of decision that, you either have to focus on common diseases or focus on rare diseases. I think the increase in diagnostic tools and supports is really exciting. We've seen a ton of progress in the last 10 to 15 years in terms of better support systems for rare diseases. The first one that's so exciting is next generation sequencing technologies. I know that this is, they're not a slam dunk, and they require a level of expertise and a level of ability to really understand the data once you do implement this tool. But I do think that it's very exciting that we have these technologies. Again, as I mentioned before, so many of these rare diseases have a genetic basis. So being able to use these technologies to get to a quicker diagnosis and not having to rely on the clinical presentation primarily of the disease, but really being able to make that diagnosis based on genetics. Also, there's been a great increase in NIH funded initiatives and resources. I'll have a slide at the end of my presentation that lists some of the resources that are available, but GARD, the Genetic and Rare Disease Information Center that's funded by NCATS and the NIH, is a great resource. There's all sorts of information, and it's really geared toward physicians, researchers. It's broken down to be geared toward physicians and researchers and patients. So there's some great tools and some great information. Also, there's been a rise in national advocacy organizations that can support patients. Again, these are umbrella organizations that try to support all rare diseases. The National Organization for Rare Disorders is the oldest. That organization was established in the 1980s, and it was really established in the push to get legislation for the Orphan Drug Act to incentivize the development of pharmaceuticals for patients with rare diseases and to increase the number of treatments. In addition to that, there's Every Life Foundation and Global Genes. So these are advocacy organizations that have really expanded over the last few years. And then the last point that I want to make is there are better technology tools to connect providers and specialists. And the Undiagnosed Disease Network is one of those. That's the graphic that I have at the top. Again, that's a NIH GARD funded initiative. And its goal is really to be able to help figure out some of those patients that are presenting with unusual symptoms, being able to get to a faster diagnosis. So I don't think that we should be thinking of diagnosing patients with common versus rare diseases. We don't have to think of that as an either or. So now that I've hopefully convinced you that diagnosing rare patients should be a priority and should be something that we think about, and that we want to reduce that time to diagnosis. I just wanted to list a few ways that I think we can improve diagnosis for the rare community. And I've broken it up into things that the healthcare system can do better, and then things that you as primary care, those of you who are primary care providers or primary care providers can do. So the first thing I want to, that I think that the healthcare system can do is include rare diseases, include those better in our medical education, whether that be at the medical school level for our future providers or CMEs. And there are some, again, in the literature, there's some good models of this. There's some, in France, it's required that all professionals have just a working knowledge of rare diseases. There's an emphasis on just raising awareness for all medical professionals about rare diseases. And then one of their medical schools does provide a 30-hour course on rare diseases specifically. I know that it's not realistic to teach medical students or care providers about each and every one of the 7,000 rare diseases, but being able to find ways to just give care providers tools for how to initiate that being able to get to a diagnosis as the primary entry point to figuring out a diagnosis for rare patients. The next two, I feel very passionate about for our healthcare system. And the first one is really recognize social determinants of health that's impacting rare patients. And this can actually, I think, be put under the healthcare system as well as primary care providers. When you have a rare patient, regardless of what that specific diagnosis is, there are just certain barriers that that patient likely faces. And I'm touched on them before, but I'm going to reiterate. The first thing that's a social determinant of health that's going to impact your patient is geography. So where that patient lives in relation to where they can access care and a specialist is really going to impact them. Can they get to a provider when they need something? How often are they seeing a specialist? I know Dr. Orchard can probably speak to this a little better than I can. He's aware of the geographical barriers that for him that allows him to interact with patients that he's cared for. Another social determinant of health that I think is very important, again, is what I mentioned in terms of health literacy. This isn't inherent to the rare patient themselves, but just really the lack of educational literature out there for rare patients about their specific disease. I think, again, this is anecdotal for me, but I feel like rare disease patients are just really all over the place sometimes in what they know about care and treatment for their rare disease. And so when you have a rare patient, really understanding that they're going to come to you with a varying degree of knowledge about their disease process. So really recognizing that there are social determinants of health that impact most rare patients. The next thing I think that the healthcare system really could help with this faster time to diagnosis is developing the public health programs and policies that do support faster diagnosis. I just listed two. I actually have a slide from one of the articles that I read with a whole host of different ways that public health can support the rare community. But I think the first one that is so important is newborn screening. I think that the COVID epidemic has really illustrated in this country, it's really highlighted our fragmented testing system in this country. And as I sort of watch the COVID epidemic unfold, it really resonates, welcome to my world with trying to get some of these rare diseases included on newborn screening panels, state by state. It's very fragmented. So first of all, only a handful of rare diseases or diseases are included on newborn screening panels. And then even once a disease is added to the RUSP, to the federal panel, it's really a state by state effort to get those diseases added to the state panels. So it's a very fragmented process. To use an example, the SMA community has had a very effective gene therapy treatment now for I think since 2018, and they were added to the newborn screening panel in 2018, so 2.5 years ago. And I believe the SMA community is up to about 32 states that are actively screening for SMA. So despite being on the federal panel and having an extremely effective treatment, SMA children are still not being screened in all 50 states for SMA. And again, SMA, just like metachromatic leukodystrophy, is one of those diseases that you really need to catch pre-symptomatically in order to administer treatments. So really doing a better job with our newborn screening, making sure that it's comprehensive and we're getting diseases on those panels quickly. In addition to that, really having good surveillance programs to be able to track prevalence and be able to really see the behaviors of these rare communities. And I think developing public health programs and policies, not siloed and not just disease by disease, but really making these programs inclusive of all rare diseases and sort of starting to build up a collective consciousness in our general public and in our healthcare about the common barriers around all rare diseases. And then the last point that the healthcare system can do to really improve time to diagnosis and care is better utilization of telehealth. I think that the silver lining of COVID, I know that you as providers, you're in the trenches with implementing telehealth, so maybe some of you would disagree with me, but I do think that for years now, the rare disease community has really been an advocate of using telemedicine and telehealth to help us access those specialists that we need. Certainly being able to use telemedicine to connect providers across state lines. Again, as I said, for the rare disease community, often our care providers, there aren't very many. And being a rare patient with an expert in your rare disease in the same state is very serendipitous, and it doesn't happen very often. So those are just a few bullet points of things that the healthcare system could do to better support the rare community. And then as primary care providers, there are a few things that I think are so important. And the first one goes back to something that we talked about earlier, but really recognizing the unique decision-making paradigm that you will have with a rare patient. And really understanding that the overlay of having a rare disease and sort of having to de facto become your own rare disease expert is really going to play into the dynamics of your relationship with rare patients. I always say to care providers, recognizing that you're going to be the care provider, but you're also going to be a learner, and that you can learn from your rare patients. And really developing a collaborative model, that shared decision-making model is so important, and it will really go a long way with your patients to have a more collaborative decision-making model. The next point is,
we're just about at 8:30, and I know you're close to the end of your slides, I think, but
yes,
maybe one more minute, and then we can take a couple of questions if there are some.
I told you this would be the slide that I wouldn't be able to stop talking about. So, and just quickly, for primary care providers to familiarize yourselves with the recent technologies, especially those genetic technologies, tools, and then familiarizing yourself with resources. And I will quickly skip over because I can definitely make this slide available, but I just made a quick list of some of the resources that are out there for providers. This list has links to nonprofits, also to the NIH resources, and then just some technology platforms. The one that I will really highlight is that second one, Orphanet. It's a very comprehensive portal for rare diseases, but it is European, so it's a little bit different. But I want to end with this last slide. So I would love to see in our medical profession an update to the Axiom that we've been talking about. And I would love to hear that we've shifted as a medical community to, when you hear hoofbeats, ask yourself if you see a horse or a zebra. And I left you with baby animal slide to brighten your day. So I think we can do better as a community. We've made a lot of improvements. The rare community, we've made so many advances in the last 10 years. And I think there's so much more that we can do to improve diagnostics for the rare community. So with that, I'm
so
going
much.
to...
But I wanted to share, sometimes the whole audience isn't able to see the questions, and I know you haven't been looking at them, but Andy Rezepka, one of our really experienced general pediatricians from the community, offered a reframing: when you hear hoofbeats, think, which I really liked.
I got that.
And Kathy Bendel, one of our neonatologists, has also shared that, and the horse zebra thing is absolutely still, people use that all the time. But I think that if we never look for a zebra, we'll never find one. So I think
that's right.
That's a good point. There was some great questions about that balance between cost in the healthcare system and the role of the primary care provider in being a good steward of our healthcare dollars, and how do you balance those two? And then someone shared that there often can be free or low cost genetic testing if an industry partner is trying to Sue Berry wants us to look for unicorns also. We're really getting fancy.
May I just say to Dr. Berry, that's exactly what Amy Givligio, I asked her for some feedback on this, and she said, look for unicorns. I think Dr. Berry knows Amy very well.
That's great. So I think that's that there may be lower cost genetic testing options for specific newer panels that are being developed.
And that is the irony, right? Because I'm well aware of the fact that with Chloe, the irony and the cruelty of her disease is you got to bring in the big gun diagnostic tools when you have a patient that doesn't seem to have serious symptoms. But in order to do anything for her, she had to be diagnosed before those symptoms really presented seriously. So it is a dilemma, and it is something that you have to weigh.
Yeah, and I think Dr. Whitley had just shared some nice comments about just the role of newborn screening and how, exactly for a patient like Chloe, that's really where our best impact can be, is making that diagnosis earlier. Sue also just shared that if you're using a industry-sponsored genetic testing panel, that there could be some privacy concerns. So it's certainly something I would recommend that us general pediatricians should not be messing around with. Once I get to the point that I think there might be a unicorn on the horizon, I'm picking up the phone, and I'm usually very upfront with families to say, I think your child may need further testing, but you don't want me to try to order that. I will not do it right, but I have a friend who knows the right things to do. So that's great. Well, thank you that was really wonderful. I would love for us to get that resource page that you put together up on our website. So we'll work on that, and just want to thank you for sharing your journey as a parent and all the wonderful advocacy you're doing on behalf of the rare disease community. Dr. Orchard, any parting words you'd like to share?
No, I just want to thank Erica again for doing this too. I think just globally, that's one of the things that the general pediatricians are going to have to struggle with is, at what point do you cross that line saying, I'm not really sure this is a horse, and what do I do from here? And what testing am I comfortable with, or when am I going to make the referral, and how long is this referral going to take, and all these other, very important questions, but are going to be practical ones as well. And so everybody that's going to be out and finishing their training and actually practicing going to have to struggle with these issues at some point. So I think it's a good thing to think about as you're leaving your training.
All right, well, have a wonderful day, everyone. Thank you so much for joining us for Grand Rounds. Next week, we're going to have some physicians from Detroit Medical Center share their really kind of cutting edge experience taking care of patients with COVID, with systemic inflammation and cardiac complications. So that's going to be a really pertinent topic that I hope you'll be able to tune in for. Have a great day, everyone.